So for those of you who don't know me, I'm Laura Hope-Stone. I'm the Health Psychologist at Liverpool Ocular Oncology Centre, also with the Clinical Health Psychology at Liverpool University's NHS Trust. I'm also a Health Psychology Research Fellow at the University of Liverpool, and I also work with patients from Ocular Melanoma UK as well. So I'm here to talk about a research study that we are about to open in the next couple of weeks, and that will be for people closest to those with uveal melanoma. I'm then going to hand you over to my colleague Poppy. So you get buy one, get one free today in psychology. So Poppy McNally is assistant psychologist. She's been working with me at Liverpool Ocular Oncology Centre. She also works with clinical health psychology and is a research assistant with me in oncology at the university. So it's not all about the patient. As we all know, there's lots of other people who are involved and very close to the patient. And for every patient that gets diagnosed, they're going to have close family and friends. So they can often experience quite a number of significant life changes. So that goes for the patient and for the people closest to them. And the loved one can take on the role of an informal caregiver. Now, I use the word caregiver, I might use the word carer, I might use the word primary support person, family and friends. There's lots of words and trying to find the right one. But basically, essentially, it's people who care and care about the other person. So the carer can be the person who provides the primary support for emotionally, psychologically and physically. And often, as many of you will know, there's a lot of lifestyle adaptations that may have to take place, especially early on following diagnosis and treatment. And for the patient and for the carer, there may be lots of things that might have to change. And some of the things that patients find difficult very, very early on is often very much the obvious one of driving. And so roles and responsibilities have to change. And we sort of take driving for granted, don't we? We can do what we like. We can go to the shop. We can go and pick up our kids. We don't have to ask somebody else to do it for us. But then that might change. So what can happen is that the dynamics can change within the domestic environment as well. People with visual problems may have difficulty doing all sorts of things. And as now we increasingly do our life admin online, if that's sort of you're the person who's looking after the car insurance and you've got to do it online and you're trying to do it on a phone and you've got poor vision, it's going to be difficult. So you might hand that responsibility over to the person closest to you. So that person might start taking on more of the roles that used to be perhaps divided more equally. So that's what I say about the roles and responsibilities changing. And the sort of dynamics of the relationship can change as well. So just a few numbers for you. So this was a few years ago now, there's about 1.5 million cancer carers in the UK. And this is just some snapshots of some challenges that work's been done. So around 50% of people who care for someone with cancer report high emotional stress related to caregiving. And 43% actually need help to manage that. And also I've put in that 25% reported financial strain. If we go back to the roles and responsibilities, it might be that if you've got vision impairment, you might have to make changes to your work roles, your work hours. And so there may be a shift of that responsibility onto the carer who may have to take up more hours, or if that's not possible, then that might place financial strain on the family. Some other challenges that have been identified for carers is, and this is from a study of colorectal patients, is that carers find it challenging to emotionally process the initial diagnosis or recurrence. They find it difficult to manage the practical and emotional aspects of patient care. And they have to face an uncertain future, as all of you are aware. And they may encounter symptom-related suffering. So when patients are struggling to see things, to do things, the things they used to do, then the carer will feel that. You care about the person who's struggling perhaps to read something, to go down the steps. So all those sort of things that can impact. So what we know from the general research that's been done on carers of people with cancer is that they say that they're often there, they can feel quite neglected. And it's not sort of purposeful, it's they can feel sort of sidelined, left out of conversations. And this might be in the clinical environment. And for a lot of people with ocular melanoma, their contact with clinicians is quite brief. They don't have that sort of continuity of care that you get perhaps with other cancers. So they might not have that opportunity to really meet and discuss things. We at Liverpool do try and involve family and friends in the aspects of treatment, especially around treatment decisions and decisions about having a biopsy. But often people will put the patient's needs over and above their own, because at the end of the day, they're saying, right, okay, well, it's not me that's having to go through this treatment, have this surgery, have their vision affected. And so they often feel they don't have legitimate needs and will often avoid reporting any unmet needs. But unsurprisingly then, if they might not be able to express those needs, then they can experience symptoms of depression and anxiety, at times at greater degree than the patients themselves. So what happens is, often is in sort of close relationships, when people are distressed, when people are feeling vulnerable and feeling scared, what we do is we go to a place of safety. And this goes back to some very early attachment theory, where we go to our primary caregiver when we're feeling frightened and scared. And when we're children, in most instances, that will be the mother. So in a close relationship, it might be that's the person you go to when you're feeling vulnerable and scared, because you want that safety. But as the carer, you might think, well, actually, I don't want to burden my loved one with how I'm feeling. They're going through enough. So relationships can start to it just can feel a bit strained. And people often need emotional support themselves. So they might not be able to express that. They might not be able to say to their partner, their friend, look, I actually need you now. So what can happen is that a conspiracy of silence can build up, where people are frightened to say, well, I don't actually want to tell this person how I'm feeling because I don't want to upset them. They're going through enough. Or you come back with that age-old thing, is I'm fine. I'm fine, I'm fine. I think everybody does that, don't they? And also, whilst we can make assumptions from the way that those closest to us behave, we can't actually read their minds. I can't read people's minds, despite the fact that I'm paid to do it. And some people say that, caring can often be burdensome. There is pressure, there is, strain, but it also can bring rewards. And in the general cancer population, when they've looked at cancer carers, they found that people can benefit from adversity and experience what we call post-traumatic growth. But this is all around sort of general cancer. But it's not about uveal melanoma. So as far as we know, there's been no work looking at the needs of carers of people with uveal melanoma. So over the last couple of years, we've been working up to do a study looking at the unmet needs of people closest to uveal melanoma. And what we're interested in doing is we want to recruit 30 people, 30 members. We're doing this in collaboration with Ocular Melanoma UK, so we will be looking to you guys to participate in this research study. We want to explore how carers processed, coped and adapted and adjusted to the changes in their life within the first year of diagnosis. We want to characterise what enhanced or impeded their capacity to make sense of their experience and how we can help them. The aim being that we can develop psychosocial interventions, and that might be something like psychoeducational material, or which would perhaps complement some of the patient-related information that I know that's being developed here with Ocular Melanoma UK. So just to say, this study has been funded by the iTumour Research Fund at the Liverpool University Hospitals charity. The investigators are myself, my colleague Poppy is here today, and we're joined with Lanira Sanmedo, who's a health psychologist, Gemma Cherry and Peter Fisher. Gemma, Peter and I have been working for many years in the psychosocial research programme at Liverpool Ocular Oncology. So we're quite a strong team. Our collaborators have been instrumental in helping us review all the public-facing materials. So Joe and Retta have been great at things going backwards and forwards. And we've been supported by Alex, who I know is helping to put this all up on this brand new lovely website. That's after he's had a rather long lie down. And also thanks to Nicolette as well, who I know is not here, but she's always on hand to help as well. So the study itself, we have submitted to, because anyone who does any research in this country, it takes a long time to get lots of things done, and getting the money approved. It's not a massive amount of money, but we got that approved. We've submitted to ethics a couple of weeks ago. They've come back with revisions and modifications, which I'll be submitting next week. So hopefully they'll approve everything and we'd be good to go. I'm sort of saying the 1st of November. So I'll tell you a little bit more about the study. So we have got an eligibility criteria. Like any research, we want a homogenous group as far as we can, and we're interested in what's going on in the first year. So we're looking for a carer, and as I say, that's the terminology we can use. Any close family member or friend of a UM survivor with a confirmed diagnosis of UM and free of metastatic disease at the time of recruitment. A carer of UM survivor about 1 to 4 years post-diagnosis. And the reason being is because we want to ask about what's going on, what went on in that first year, what helped, what didn't help, what support people might need. And beyond 4 years, we get a problem with recall and what people remember. We need a person who provides the emotional, social and physical support to that survivor. Not currently being treated for cancer, can have had a cancer diagnosis in the past, but not having active treatment or palliative care. Adult over 18 with no upper age limit and able to speak and understand English. So that's the criteria. Okay, so this is going to be a qualitative study, an exploratory study. It's not about numbers, it's about hearing people's perceptions of their experience, their lived experience. And we'll be, to understand their perceptions and behaviours, to get a clearer understanding of their experience and what happened over time. And we will be drawing on the individual's personal accounts of their experience. So what does this entail for the person who's participating? So these will be semi-structured interviews. So we do have a topic guide where we'll start to explore various aspects of people's experiences. Because just to reiterate, we don't really know anything because it's not been looked at before. So this is where the qualitative work comes in, where we're hearing people's stories, hearing their experiences. The topic guide will change and be modified as we progress through the analysis. So we use the verbatim transcripts, which will be anonymised before analysis. We use the words and that's our data. And we will cycle back between the data and what people are saying, the topic guide, and revise the topic guide. Maybe there's areas we want to probe and look a bit more deeply into. So it will change over time, so not everyone's going to get exactly the same questions. Now, the interviews will be online or by phone and digitally recorded. So the online will be on Teams. The University of Liverpool won't allow us to use anything else, and they will be recorded. But obviously, they'll be, we'll seek your permission to do that if someone's interested in the study, and then we'll go through the consent process. And as I said, themes will be generated. And findings will be compared to the literature and what we know about other cancer populations as well. To help guide the interviews and describe the sample, we've got some questionnaires that we'll ask people to do prior to the interview. And the reason we're doing that is because we want to look at those responses and to see if there's anything there that we need to sort of just probe a bit and explore a bit in any more detail. They will be done online as well, and they can be, but just to say, these can be paper questionnaires, and the interview can be done by phone. So we want it to widen access to everyone, even if they haven't perhaps got access to the internet or feel uncomfortable using video online. So the interviews themselves, so because in my role at Liverpool and Ocular Melanoma, there may be occasions where I've had contact with the participant, but also with the participant person that they support, the patient, either at Liverpool or under this auspices of Ocular Melanoma UK. If that is the case, there'd be a conflict of interest, and I would need to pass, that interview would then be conducted either by Poppy or Lanira Semedo. And that's always good anyway, because we get sort of different perspectives as well. So that's what we would do. This is just a mocked up page Alex did for us. And so what will happen is there's going to be an advert on the website coming to you soon, and that will just basically describe what I've just said. There will be a link to the participant information sheet, and you'd click on that, and that will take you through to the information sheet. And in that, it's got all the detail, more detail than how I've described it today. It talks about informed consent, data protection, confidentiality. We'll also give sources of support as well. Within that, there'll be another place to go. So if you were interested in taking part and you'd like to discuss the study with myself, then what you can do is you can then fill out the consent to contact form. So that will take you to this form, and essentially what that's doing is giving myself or Poppy or Lanira permission to contact you to have a discussion about it. So, but if after the discussion you think, actually, no, I don't really want to do this, then that's absolutely fine. You can say, right, I don't want to. In terms of sort of withdrawing from the study, if you want to withdraw at any point, and if, for instance, during the interview you thought, actually, no, this is too difficult, I don't want to talk about this, I'd like to stop, we can stop the interview, we can stop the recording. You might want to say, okay, I'll come back to this, but if you think, no, this is too difficult, then we wouldn't push you. It would be your choice, and you can withdraw at that stage. The only time you can't is once we've got the data and we've anonymised it, then I'm afraid you can't withdraw. But it will be anonymised and you won't be able to be recognised. So what we do with the transcripts is we redact anything that would identify us. So we'd put Mr. X or patient member X went to see Dr. X at Hospital X, that kind of thing. So that's how we'll maintain your personal information. Now there will be payment for taking part, and that will be a £30 high street voucher, which will be offered by Ocular Melanoma UK. So as I say, we're working with Joe and Alex and Nicolette to get this study up and running, and I'm hoping that people will want to participate. As I say, it's not been done before, it's new, and we're in an ideal position to do it.